treatments of adrenal insufficiency and Addison's disease. Pharmacotherapy of Addison's disease. Glucocorticoid replacement therapy. Replacement doses for glucocorticoids are the same for both primary and secondary adrenal insufficiency. Hydrocortisone is the first-line agent as it is the true replacement of cortisol. It is a potent glucocorticoid with some mineralocorticoid activities. It is short-acting, therefore 2 to 3 doses must be given throughout the day. 15 to 25 mg per day is given in 2 doses regimen. Highest dose is given in the morning at awakening. Next dose is given at early afternoon, which is 2 hours after lunch. In 3 doses regimen, first dose is given in the morning after awakening. Second dose is given at lunch and the third is given in evening before 6 p.m. The doses are doubled during stress, supplemented by salt-retaining fludrocortisone. Cortisone has the same effects and mechanism of action as hydrocortisone. It requires enzymatic activation in the liver that causing its effect is slower and have a less predictable onset. It is also a short-acting agent. 2 to 3 doses weighing 20 to 35 mg must be given throughout the day. Its daily and during stress dose regimens are same as hydrocortisone. For long-acting glucocorticoids, prednisolone is the preferred alternative to hydrocortisone in patients with primary adrenal insufficiency who are non-compliant. Its doses are 3 to 5 mg daily 2 times per day. The timing is the same as hydrocortisone and double the doses during stress. Prednisolone is a potent glucocorticoid with less mineralocorticoid activity than short-acting glucocorticoids. Its long-acting property may prevent excessive high peak levels and periods of inadequate replacement that may occur with hydrocortisone and cortisone. Dexamethasone is the least preferred alternative to hydrocortisone in patients with primary adrenal insufficiency due to high risk for Cushingoid side effects because of dose titration difficulties. Monitoring the glucocorticoid replacement therapy. Clinical assessment of body weight, postural blood pressure, energy levels and signs of flank glucocorticoid excess are used to monitor glucocorticoid replacement therapy. Mineralocorticoid replacement therapy is necessary in all primary adrenal insufficiency patients. It is to prevent sodium loss, intravascular volume depletion and hypercalcemia. Fludrocortisone 50 to 100 microgram per day is preferred choice with no salt intake restriction. It is a potent mineralocorticoid with some glucocorticoid activity. Dose reduction is suggested if hypertension developed during fludrocortisone therapy. Monitoring mineralocorticoid replacement therapy. Clinical assessment of salt craving, postural hypertension or edema and blood electrolyte measurements are used to monitor mineralocorticoid replacement therapy. Androgen replacement therapy. Usage of progesterone or dehydroepiandrosterone (DHEA) may improve well-being and sexuality in women with adrenal insufficiency. It is recommended in women who have primary adrenal insufficiency and low libido, depressive symptoms and/or low energy levels despite optimal glucocorticoid and mineralocorticoid replacement therapy. Initial period of usage is 6 months. If no benefits observed, discontinue use of this agent. Pharmacotherapy of adrenal crisis. Initial goals of therapy are treatment of hypotension, correction of electrolyte abnormalities and correction of cortisol deficiency. The treatment consists of large amounts of parenteral hydrocortisone with correction of fluid and electrolyte abnormalities and treatment of precipitating factors. Immediate IV dose of hydrocortisone at an appropriate stress dose such as 100 mg IV is given every 8 hours until the patient is stable. The dose is then gradually reduced, achieving maintenance dosage within 5 days. Prednisolone is the alternative if hydrocortisone is not available. Dexamethasone, hydrocortisone or any glucocorticoid IV boluses preparation may be used in patients with known diagnosis of adrenal insufficiency. 2 to 3 liters of saline solution, such as 0.9% or 5% dextrose in 0.9% saline, should be administered as quickly as possible to restore intravascular volume and replace urinary salt losses. Monitor for signs of fluid overload. Mineralocorticoid replacement is not needed acutely because its sodium-retaining abilities become apparent only after several days. Adequate sodium replacement is achieved by IV saline infusion. Mineralocorticoid replacement may be started once saline infusion is discontinued and when the total hydrocortisone dosage has been reduced to 50 mg per day. Monitor blood glucose of the patient. If blood glucose is less than 4 mmol per liter, give 20% dextrose over 10 to 15 minutes stat. Identify and treat underlying problem that triggered the acute crisis. Most patients who experience adrenal crisis have primary adrenal insufficiency and require lifetime glucocorticoid and mineralocorticoid replacement therapy. Patients' education regarding corticosteroids replacement therapy. Patients should be taught of the nature of hormone deficiency and the rationale of steroid replacement therapy. Patients should be educated about glucocorticoid adjustments in stressful events and adrenal crisis prevention strategies. Patients' education regarding glucocorticoid therapy. Patient must be taught to double or triple their dose of glucocorticoid replacement temporarily if they have febrile illness or injury. If vomiting occurs soon after oral dose, patient should be instructed to take second dose. Glucocorticoid injection should be provided for self-injection in cases of major injury, severe vomiting and acute adrenal insufficiency if the patient becomes unresponsive. Regarding mineralocorticoid therapy, no need for patient to increase mineralocorticoid therapy during illness unless critically ill. Patients should be instructed to maintain adequate salt intake, which is 3 to 4 grams per day. They may need to increase dose of fludrocortisone and to add extra salt to diet during hot weather, times of strenuous exercise or sweating. If the patient has history of excessive steroid use, educate patient about risks of excessive steroid use. Treatment of pheochromocytoma. Goals of pharmacotherapy of pheochromocytoma. To achieve adequate blood pressure control to avoid hypertensive crisis during intraoperative handling of tumor. To minimize adverse effects of anesthesia. To maintain stable blood pressure during surgery. Alpha-adrenergic blockade is the first-line therapy used prior to surgery to control blood pressure. After achieving adequate alpha blockade, the patient can be treated with beta blockers to achieve heart rate control. Target blood pressure is less than 120 per 80 mm mercury in sitting position and systolic BP more than 90 mm mercury on standing. Phenoxybenzamine is a powerful non-selective irreversible alpha-adrenergic blocker. It is used to control hypertension caused by excessive catecholamine release by pheochromocytoma. Initial dose is 10 mg 2 times per day and could be increased by 10 to 20 mg every third day. Advantages of phenoxybenzamine. It has a long duration of action that permits twice-daily dosing. It also has a non-competitive blockade of alpha receptors that prevents episodic surges of catecholamine releases during pre- and post-operative period. It has onset of action within a few hours and persists for up to 3 to 4 days. Disadvantages of phenoxybenzamine are adverse effects such as reflex tachycardia, persistent post-operative hypotension, somnolence, stuffiness of nose, headache and postural hypotension requiring IV fluid replacement. Selective alpha-1 blockers such as prazosin, doxazosine and terazosin selectively block alpha-1 adrenoreceptors. They are better tolerated than phenoxybenzamine. However, they are less effective than phenoxybenzamine. They also cause first-dose hypotension, which is sudden severe drop of blood pressure after first dose. They also have a poor intraoperative blood pressure control. Prazosin has short duration of action. It must be given 1 mg 3 times per day initially and increased to maximal doses of 12 mg per day. Doxazosine has a longer half-life that allowing once daily dosing. Beta-adrenergic blockade is done by using beta blockers such as propranolol, non-selective, and atenolol, beta-1 selective. Once adequate alpha blockade is achieved, beta blockers are used to control reflex tachycardia. They are given only after alpha blockade has been induced. Without alpha blockade, unopposed catecholamine-induced alpha stimulation will cause paradox increased in blood pressure that leads to hypertensive crisis. Target pulse rate is 60 to 80 per minute. Usually 10 mg 4 times daily of propranolol is used and later converted to daily long-acting dose. Labetalol has alpha to beta antagonistic ratio of 1 to 7 orally. So it has inadequate alpha blockade with more effect on heart rate and may cause paradoxical hypertension. Calcium channel blockers such as nifedipine and amlodipine block slow calcium channels to prevent calcium ion flow into the vascular smooth muscle cell, thus cause vasodilatation, then reduce afterload and peripheral resistance and lead to decreased blood pressure. They are used as add-on treatment to alpha blockers to further improve cardiovascular function perioperatively. Supply alpha blockers in patients with inadequate blood pressure control. Obviate the need to increase the dosage of alpha blockers. They could be used alone without alpha and beta blockers for low-risk patients, as CCB does not interfere with plasma normotenephrinoxase, and if alpha blockers induce sustained hypotension in patients with only intermittent hypertension. Metirosine inhibits tyrosine hydroxylase, which inhibits synthesis of catecholamines by the tumor. It is started with doses of 250 mg thrice daily and gradually increased to 1.5 to 4 g daily. It is used as short-course treatment because of its side effects. It is also used if other agents are ineffective or when tumor destruction will be marked. Surgery is the treatment of choice for most cases of pheochromocytoma. It is microscopically difficult to determine if pheochromocytoma is malignant. So each pheochromocytoma should be regarded as potentially malignant during surgery. The entire gland and the surrounding tissues must be removed to prevent recurrence of local disease. Preoperative pharmacologic management involves alpha and beta adrenergic blockades to control blood pressure and prevent hypertensive crisis during the surgical procedure. A high-sodium diet with high fluid intake is recommended pre-operation to prevent post-operative volume depletion. Treatment of congenital adrenal hyperplasia. Congenital adrenal hyperplasia caused by specific defects in synthesis of cortisol. A lack of P450C21 causes defect at 21-hydroxylase. This is the most common manifestation. In this disorder, there is a reduction in cortisol synthesis, thus leads to compensatory increases in ACTH release. Adrenal gland becomes hyperplastic and produces abnormally large amounts of precursors 17-hydroxyprogesterone, thus diverted to the androgen pathway and leads to masculinization. B. Lack of P450C11 causes defect of 11-hydroxylase. In this disorder, large amounts of deoxycorticosterone produced that has mineralocorticoid activity that increases hypertension with or without hyperkalemic alkalosis. C. Lack of P450C17 causes defect of 17-hydroxylase. This disorder causes hypogonadism and mineralocorticoid excess. Optimal glucocorticoid dosing is aimed to replace deficient steroids, minimize adrenal sex hormone and glucocorticoid excess, thus preventing virilization, optimizing growth and protecting potential fertility. During infancy, initial reduction of markedly high levels of adrenal sex hormones may require hydrocortisone up to 25 mg per square meter per day, but typical dosing is 10 to 15 mg per square meter per day in 3 divided doses. Excessive doses, especially in infancy, cause persistent growth suppression, obesity and other Cushingoid features. Therefore, avoid complete adrenal suppression. Hydrocortisone is preferred in infancy and childhood. Long-acting glucocorticoids may be used at or near the completion of linear growth. Prednisolone needs to be given twice daily, at 2 to 4 mg per square meter per day. Dexamethasone dose is 0.25 to 0.375 mg per square meter per day and given once daily. Fludrocortisone is used for 21-hydroxylase deficiency that should be diagnosed in the newborn period. 11 and 17-hydroxylase deficiencies don't need fludrocortisone because they have adequate mineralocorticoids activities. Dosage requirements in early infancy range from 0.05 to 0.3 mg per day, whereas typical maintenance doses are 0.05 to 0.2 mg per day, depending on the sodium intake. Therapy will reduce vasopressin, ACTH levels and lower dosage of glucocorticoid required. The need for continuing mineralocorticoids should be assessed based on plasma renin activity and blood pressure. Sodium chloride supplements are often needed in infancy at 1 to 3 grams per day, or 17 to 51 milliequivalent per day, distributed in several feedings. Monitoring may be accomplished based on physical and hormonal findings suggestive of excessive or inadequate steroid therapy. Laboratory measurements may include serum and plasma electrolytes, serum 17-hydroxyprogesterone, cortisol, and/or testosterone, and plasma renin activity or direct renin, every 3 months during infancy and every 4 to 12 months thereafter. The time from the last glucocorticoid dose should be noted. The diurnal rhythm of the adrenal axis should be taken into account. Laboratory data will indicate a need for dose adjustments before physical changes. Growth and skeletal maturation indicates inadequate or excessive dosing. Management of salt-losing crisis in CAH. For patient in shock, use normal saline 0.9% given by bolus 10 to 20 milliliters per kilogram. Correct hypoglycemia if present by using 2 to 4 mg per kilogram of 10% glucose. Rehydrate using normal saline 5% dextrose. Monitor hydration status, blood pressure, heart rate and glucose level. Hypertonic saline or 5% dextrose only should not be used because it can worsen hyponatremia. Treatment of central precocious puberty and advanced bone age. Continuous administration of a GnRH agonist is indicated for treatment of central precocious puberty, which is early onset of secondary sex characteristics before 7 to 8 years in girls or 9 years in boys. Before embarking on treatment with a GnRH agonist, one must confirm central precocious puberty by demonstrating a pubertal gonadotropin response to GnRH, a test dose of a GnRH analog. Treatment is typically indicated in a child whose final height would be otherwise significantly compromised, as evidenced by a significantly advanced bone age. Treatment usually carried with monthly intramuscular depot injection of leuprolide acetate or once-yearly implant of histrulin acetate or daily subcutaneous regimens and multiple daily nasal spray regimens of GnRH agonists such as goserelin, nafarelin and triptorelin. Treatment is generally continued to age 11 in females and age 12 in males. Gonadotropin-releasing hormone, GnRH, is a decapeptide found in all mammals. Gonadorelin is an acetate salt of synthetic human GnRH. Synthetic analogues of GnRH include goserelin, histrulin, leuprolide, nafarelin and triptorelin. These analogues all have D-amino acids at position 6, and all except nafarelin have ethylamide substituted for glycine at position 10. Both modifications make them more potent and longer-lasting than native GnRH and gonadorelin. Half-life of IV gonadorelin is 4 minutes, while half-life of subcutaneous and intranasal GnRH analogues is about 3 hours. Preparations with a range of durations of action from several hours for daily administration to 1, 4, 6 or 12 months in depot forms, subcutaneous and intramuscular injections, nasal spray, nafarelin, and subcutaneous implant. The goals of surgery are to make genital appearance compatible with gender, to unobstruct urinary emptying without incontinence or infections, to have good adult sexual and reproductive function. The procedure should be anatomically based to preserve erectile function and the innervations of the clitoris. The surgery should emphasize in functional outcome rather than a strictly cosmetic appearance. If the patient is assigned female, she will undergo removal of all testicular tissue and vaginoplasty after puberty. If the patient is assigned male, he will undergo orchidopexy, removal of all Mullerian structures and surgical repair of hypospadias. Gonadectomy is to be considered if he has dysgenetic gonads. That's the end of lecture. Thank you.